Welcome back to the deep dive. Today we are shifting gears a little bit. We're getting very specific, very technical, and, well, frankly, a little bit high stakes.
We are. This is a specialized session we've designed for our listeners who are preparing for the Gujarat University MD anesthesiology exams.
Exactly. But even if you're not, don't tune out. Because what we're about to get into is, I think, what many would consider the final boss of airway management.
Oh, absolutely. We're talking about the anesthetic management of TM joint ankylosis and maxillofacial trauma.
With a very special emphasis on airway management, of course. Now, to put this together, we've gone through the heavy hitters.
We have. We've got Miller's anesthesia, the Bible, as you say. We've looked at Morgan and Mikhail. And we're leaning pretty heavily on long and short cases in anesthesiology by Puneet Khanna.
Right, and we've also pulled from some specific DNB and university question banks to really tailor this.
And the goal here is, pretty simple. We want to help you build a model answer. So if you get this as a 20-mark long question or you're standing there in your viva voce.
You're not just stammering.
Exactly. You have the structure, you have the keywords, and you have the clinical reasoning to just handle it with complete confidence.
Okay, so for today's deep dive, I'm going to be the eager postgraduate student. I've got my notes out. I'm a little bit nervous about this whole thing.
And I'll be the senior faculty, the examiner. It's a role I'm comfortable with. Let's break down these nightmares.
Perfect. Let's start with the big picture then. Why are these two conditions, TMJ ankylosis and maxillofacial trauma, why are they always lumped together in exams, and why do you call them nightmares?
Well, it really boils down to one fundamental problem, the shared airway.
The shared airway.
Yes. In almost every other surgery, the anesthetist, you secure the tube, you tape it down, and you sort of step back. The field is yours. But here,
you're right in the middle of the action.
You and the surgeon are fighting for the exact same real estate. But even more than that, these two conditions are the perfect storm for a cannot intubate, cannot ventilate scenario, the dreaded CICV.
Right, because the anatomy itself is just, it's broken. It's not normal.
Precisely. You have distorted anatomy.
Yeah.
You've got bleeding that obscures your view, and you have severely limited access.
Right.
With TMJ ankylosis, you could say the door to the airway is locked shut.
And with trauma.
With trauma, the door might be hanging off its hinges, the frame is shattered, and the hallway is on fire.
Wow, that's a very effective and terrifying visual.
It should be. It frames the problem. Now, for the exam, you'll see this come up in a couple of ways. You'll either get the big, long question, which needs that full, structured essay.
Assessment, preparation, plan A, B, C.
All of it. Or you might get a short note, which will probably ask you to focus on a specific technique, something like awake fiberoptic intubation.
Got it. Okay, so let's tackle the first half of this terrifying duo. Part B, TM joint ankylosis. This seems to be an incredibly high-yield topic for the university papers.
It is, absolutely. So if you're writing this out, you start with a solid definition. TM joint ankylosis is the fusion of the mandibular condyle to the glenoid fossa.
So the ball and socket of the jaw joint.
They become one solid piece of bone. The direct result is a restriction, often a very severe restriction, of mouth opening.
And when we talk about etiology, the causes, what should be on that list?
Number one, with a bullet, is trauma. Specifically, trauma to the chin.
The chin. That seems a bit indirect, not the jaw itself.
Well, think about the physics. The force gets transmitted. You take a hard fall as a child, you hit your chin on the pavement, and that force drives the condyle right up into the joint space.
Ah, I see.
It causes an intracapsular hemorrhage, a bleed inside the joint capsule. That blood eventually organizes, calcifies, and turns into bone. It's surprisingly common.
Okay, so trauma first. What's next?
Next is infection. Things like a bad middle ear infection, otitis media, or mastoiditis. If that infection spreads to the joint, it can cause the same fusion process.
And I've seen mentions of congenital or systemic causes as well. Are those important to include?
Yes, but they're much rarer. You should definitely mention things like ankylosing spondylitis or rheumatoid arthritis. Miller's very clear on this. But realistically, for your exam case, it's almost always going to be post-traumatic.
And we should probably mention the classification, right? Bony versus fibrous, unilateral versus bilateral.
Briefly, yes. It shows, the topic in depth.
Yeah.
But then you need to immediately pivot to the elephant in the room, the anesthetic significance.
Which is the fixed mechanical inability to open the mouth.
And this brings us to what is probably the single most critical concept in this entire deep dive. If you remember nothing else from this, remember this. In TMJ ankylosis, the restriction is mechanical. It is bone fused to bone.
Okay. And the implication of that is?
The implication is that it is not caused by muscle spasm.
Yeah.
It is not trismus. Therefore, and this is the crucial part, muscle relaxants will not help you open the mouth.
Right, so if I'm in that situation and I think, oh, the jaw's tight, let me give some succinylmethonium to relax it.
You have just created an absolute unmitigated disaster. You've induced apnea, so the patient stops breathing, but the mouth is still fused shut. You can't ventilate, you can't intubate.
That's an immediate fail in Aviva, isn't it?
It's an immediate fail in Aviva and a potential catastrophe in real life. So bold, underline, highlighted in your mind, no muscle relaxants until the airway is definitively secured.
Okay, point taken, loud and clear. So let's dig into these airway challenges a bit more. It's not just about not being able to get a larynxo blade in, is
No,
it?
not at all. It's really a cascade of problems. So problem one, yes, direct laryngoscopy is impossible. You need at least some mouth opening to insert the blade, and you don't have it.
But what about just mask ventilation? Can't we just support them with a bag and mask?
You'd think so, but even that can be incredibly difficult. Many of these patients, especially if the injury happened in childhood, have significant retrognathia.
Which is a receding chin.
A very small, underdeveloped mandible, they call it bird-like facies. The growth center in the condyle was destroyed by the initial trauma, so the jaw just never grew properly.
And that makes a mask seal really hard to get.
Very hard. And what's more, because the jaw is so small, there's very little space for the tongue. So the tongue itself is pushed back posteriorly, causing a baseline level of obstruction even before you do anything.
You see this in syndromes too, right? Like Pierre Robin or Treacher Collins.
Exactly. And the pediatric considerations here are massive. These children often suffer from obstructive sleep apnea, OSA, because of that small jaw. They can also be malnourished because they simply can't chew solid food.
So you're walking into a situation with a difficult airway in a potentially frail, nutritionally compromised child.
That's the scenario.
Okay, let's move on to the preoperative assessment.
Mhm.
If I'm writing this up for the exam, what are the absolute key measurements and assessments I need to list?
The single most critical measurement, the one you lead with, is the interincisor gap.
And how small are we talking here? What's the cutoff for difficult?
Well, anything less than 3 centimeters is going to predict some difficulty. But in severe ankylosis, you're often looking at less than 5 millimeters.
5 millimeters.
Or less. Sometimes it's 0. The teeth are clenched shut permanently.
Wow, you can barely fit a tongue depressor in there, let alone a breathing tube.
Exactly. After that, you want to check the thyromental distance, which is almost always reduced. And this is very important. You must check nasal patency.
Because the plan is almost certainly going to involve going through the nose.
The nose is your primary route of entry. You have to meticulously check both nostrils. Is there a deviated nasal septum, DNS? Are there polyps? The last thing you want is to start your awake fiberoptic procedure and hit a solid wall of cartilage.
That would be a bad time to discover that. What about imaging?
Yes, you have to mention imaging. You can reference Miller here. X-rays are good, specifically the lateral oblique views, but a CT scan is even better. It gives you a 3D picture of the fusion and, crucially, the amount of airway space you have to work with behind the tongue.
Okay, this is great. Let's get to the absolute core of the exam answer. The anesthetic management. We've established we can't just put them to sleep and paralyze them. So what is the gold standard?
The gold standard, the term you must use in your answer, is awake fiberoptic nasal intubation. AFO.
Awake. That sounds quite unpleasant for the patient.
It can be, which is why it requires immense skill and, just as importantly, meticulous patient preparation. Puneet Khanna's long and short cases gives a fantastic protocol for this.
Okay, so walk me through that preparation.
It starts with drying up secretions. The fiber optic scope lens is tiny, and a single drop of saliva can completely obscure your view.
So an anticholinergic, glycopyrrolate?
Yes, glycopyrrolate is perfect, usually about 4 to 8 micrograms per kilogram, given intramuscularly around 45 minutes before the procedure. It creates a nice, dry field to work in.
Okay, so the field is dry. What's next?
Topicalization. You have to anesthetize the entire pathway. The scope and the tube will travel. This is what makes it tolerable for the patient.
How do we do that?
It's a multi-step process. You might start with a 4% lignocaine nebulization for the whole airway. Then you use viscous lignocaine jelly on a swab for the nose. And then, for the deep structures, you perform specific nerve blocks.
Which blocks are we talking about here?
The two key ones are the superior laryngeal nerve block, which numbs the structures above the vocal cords, and the transtracheal block, which numbs the trachea and the cords from below.
So if you get those right, the patient won't cough or gag when the tube passes through the cords.
That's the goal, a calm patient and a clear view. And don't forget the vasoconstrictors, a few drops of xylometazoline in the nose to shrink the mucosa and prevent bleeding.
Right. So preparation is key. But what if we don't have a fiberoptic scope? Or what if the patient is a terrified 5-year-old who just will not cooperate for an awake procedure?
An excellent question. This is where you must demonstrate that you have a plan B and a plan C. If AFOI is not an option, you might consider an inhalational induction.
With sevoflurane, I assume.
Sevoflurane is the agent of choice. The critical part is that you maintain spontaneous ventilation. You keep them breathing on their own throughout.
And then what? Once they're asleep but still breathing.
Then you might have a few options. You could attempt a blind nasal intubation, which is a bit of a lost art, but still a valid exam answer. Or if you can get even a tiny bit of mouth opening, you might be able to use a specialized videolaryngoscope.
But the one thing you are not doing is...
You are never, ever giving muscle relaxants. Not until you have a confirmed tube in the trachea, you see the capnography waveform, and you hear breath sounds, period.
And the ultimate backup, the final safety net if everything goes wrong and you lose the airway.
Tracheostomy. And here's a key expert note to add to your answer. You must mention that you have psychologically prepared the patient and the parents, in the case of a child, for the possibility of an awake tracheostomy.
So that conversation happens beforehand.
It has to. Because if you're in a can't intubate, can't ventilate situation with a fused jaw, you cannot intubate orally. You probably can't even get an LMA in. Your only way out is through the front of the neck.
The stakes could not be higher. Okay, so let's fast forward. The tube is in, surgery goes well, the surgeon has released the ankylosis, the jaw opens. Time to celebrate and pull the tube out.
Absolutely not. This is a classic trap. Just because the bone has been cut does not mean the airway is safe. In fact, it can be even more dangerous.
Why is that?
Because now you have surgical edema, you have bleeding, you have swelling from the manipulation, all happening right next to the glottic opening. The space can disappear very quickly.
So what's the correct extubation strategy?
The rule is you extubate only when the patient is fully, completely awake and has all their protective reflexes back. And long, short cases makes a great point here. If the surgery was very extensive or there's a lot of visible swelling, the safest plan is to leave the patient intubated overnight in the ICU.
Better safe than sorry.
In airway management, it's the only way to be.
All right, let's pivot. That was the chronic, predictable, planned for nightmare. Now for the acute, chaotic, unpredictable nightmare. Part C, maxillofacial trauma.
Yes. Examiners love this topic because it's not just about technical skill. It tests your judgment and your ability to think clearly under immense pressure.
So for the overview, we're talking about high-velocity injuries.
Exactly. Road traffic accidents, assaults, significant falls. And the key concept you must introduce immediately is the multi-system patient.
It's almost never just an isolated facial injury, is it?
Almost never. If the force was great enough to shatter the bones of the face, you have to assume it was also transmitted to the head, causing a potential brain injury, and to the neck. You must assume a cervical spine injury is present until it is definitively cleared.
Okay, so the anesthetic priority is A for airway, straight out of the ATLS protocol, but the injury itself is what's threatening the airway.
It's a true paradox, and I like to call this the messy airway.
Paint that picture for us. What does messy mean in this context?
It means you look into the mouth and you see chaos. There's active bleeding fitting the pharynx, and blood is the enemy of fiber optics. That gold standard we just spent so much time on for TMJ, it might be completely useless here.
Because you just can't see anything through a pool of blood.
It's like trying to navigate in a blizzard with a flashlight. Impossible. On top of the blood, you have loose teeth, you have sharp fragments of bone, maybe a shattered denture. All of these are foreign bodies that can be aspirated.
And then comes the swelling.
Massive, rapidly progressing edema. A hematoma in the floor of the mouth can swell so much it pushes the tongue up and back, completely obstructing the pharynx. It's like a traumatic Ludwig's angina.
And your landmarks for intubation are gone.
They're gone. If the mandible is in pieces or the maxilla is detached and floating, what we call Lefort fractures, then the normal anatomy you rely on for laryngoscopy simply doesn't exist anymore.
So preoperative assessment, we're in the ER, it's loud, it's chaotic. ATLS protocol is our guide.
Yes. And the first rule is to treat every single trauma patient as a full stomach. They have not been fasting. The risk of aspiration is extremely high.
And the C-spine.
You assume it's unstable. This is non-negotiable. This has huge implications for how you manage the airway because you cannot do the classic sniffing position where you extend the neck.
You have to keep the neck in a neutral position.
at all times.
Okay, so let's put it all together. We can't use fiberoptic because of the blood. We can't extend the neck because of the C-spine. The landmarks are gone. How on earth do we manage this airway?
The standard approach, assuming the anatomy looks at least somewhat manageable, is a rapid sequence induction, or RSI, combined with manual inline stabilization, or MILS.
Can you explain MILS for the listener?
MILS is where an experienced assistant kneels or stands at the head of the bed and holds the patient's head, specifically the mastoid processes, to keep the head and neck perfectly still and aligned while you perform the laryngoscopy and intubation.
Okay. Now, the textbooks have a huge flashing red warning light when it comes to trauma and the route of intubation, specifically going through the nose.
Yes, this is an absolutely critical exam core point. You must state that nasal intubation is contraindicated in patients with Lefort 2 or Lefort 3 fractures, or in any patient with a suspected basilar skull fracture.
And why is that?
It's because of the risk to the cribriform plate. This is the very thin, sieve-like bone at the base of the skull that separates the nasal cavity from the brain. In these types of mid-phase fractures, that plate can be shattered.
So if you try to pass a tube up the nose,
You could, and people have, passed the endotracheal tube directly into the cranial cavity, into the brain.
that is a catastrophic, completely unsurvivable complication.
It is. Both Miller and Morgan are extremely emphatic about this. So if you see the signs raccoon eyes, CSF fluid leaking from the nose, the nasal route is an absolute no-go.
So we have to go oral. But what if we try the RSI with MILS and we just can't see the cords or we can't get the tube in?
Then you have declared can't intubate, can't ventilate, and you must immediately move to a surgical airway. There's no time to waste.
So cricothyrotomy.
A needle or surgical cricothyrotomy is the primary rescue technique. It's the fastest way to get oxygen into the patient. Or in some cases, like a direct crushing laryngeal injury, a primary tracheostomy might be the first and only plan.
Okay, let's get into the OR. The tube is in, the surgeon is working. You mentioned something earlier about a throat pack. Why is this such a big deal for exams?
The throat pack. It's a simple thing that has huge medical legal implications. The surgeon will place a large gauze pack at the back of the throat to soak up blood and catch bone chips.
Which makes sense to prevent them from being swallowed or aspirated.
It's a very useful tool. But the anesthetist's responsibility is twofold. One, you must document that a throat pack was placed. And two, you must ensure and document that it was removed before extubation.
I can see why, if you forget it.
If you forget it and pull the breathing tube, the patient takes a big gasp and that gauze pack gets sucked down and completely obstructs the trachea.
Yeah.
It's a preventable disaster.
Total obstruction, a nightmare. Okay, let's talk about getting them out of the OR. Part D, post-operative care for these trauma patients.
The extubation criteria for trauma are even stricter than for elective cases. They must be 100% awake. Their protective reflexes, like coughing and swallowing, must be fully intact. There can be no active bleeding, and the edema must be minimal.
And what about this specific situation? Intermaxillary fixation, or IMF, that's when their jaws are wired shut post-op, right?
Correct. The surgeon wires the upper and lower teeth together to allow the fractured bones to heal in alignment. So the patient leaves the operating room completely unable to open their mouth.
That sounds absolutely terrifying, especially if you feel nauseous.
It is. The risk of vomiting and aspirating is huge. That's why antiemetic drugs are mandatory, not optional. But the key safety point here, the one you have to mention, is the wire cutters.
The wire cutters, where do they need to be?
They must be immediately accessible at all times. That means they're taped to the patient's chest or to the head of the bed during transport to recovery and while they're in the PTCU.
And everyone needs to know where they are.
Everyone. The nurse, the porter, the recovery staff. If that patient starts to vomit or shows any sign of airway obstruction, the first action is to cut those wires and get the mouth open. It is a life-saving detail.
Absolutely. Okay, we're in the home stretch now. Part E, comparison and exam integration. This is where we tie it all together for the big marks. Let's create that mental comparison table for the listener. TMJ ankylosis versus maxillofacial trauma.
Let's do it. Visualize two columns. Column A is TMJ ankylosis. The nature is chronic. It's a slow onset. The status is elective surgery. The stomach is empty because they've fasted.
And the airway plan is planned and controlled.
Exactly. It's a planned airway, typically using awake fiberoptic intubation, and the neck is usually mobile, unless they have a coexisting condition like ankylosing spondylitis.
Okay, now for column B, maxillofacial trauma.
The nature here is acute. It's an emergency. The status is a crash surgery. The stomach is full, creating a high aspiration risk.
And the airway plan is reactive?
It's a crash airway,
Hmm.
usually RSI with Mills, with a high likelihood of needing a surgical rescue. And the neck is assumed to be unstable. There is always a C-spine risk.
That is a perfect, concise summary. Now let's hit those Viva traps, the tricky questions the examiner might throw at you to see if you really understand.
Okay, trap number 1. The examiner leans in and says, "Doctor, your patient has severe bony ankylosis. The mouth opening is only 2 millimeters. Can you just give a little bit of succinylcholine to relax the jaw?"
And the only correct answer is,
A firm, confident no. You would then explain that the restriction is bony, not muscular, and that muscle relaxants will cause apnea without improving mouth opening, creating a CICV situation.
okay, Viva trap number 2.
The examiner says, your trauma patient has a Lefort-3 fracture. They have bilateral raccoon eyes and clear fluid leaking from the nose. The mouth is full of blood. Should we attempt a blind nasal intubation?
Absolutely not. You'd explain the risk of intracranial placement due to a probable basilar skull fracture.
Perfect. And the most common student mistake I see is forgetting the C-spine in the heat of the moment with a trauma case. They get so focused on the bloody airway that they instinctively extend the neck to get a better view.
And potentially cause a devastating spinal cord injury.
You must always, always respect the spine.
Okay, for the written exam, the 20 marker, you mentioned drawing diagrams. Which ones give the most bang for your buck?
You should absolutely draw the ASA difficult airway algorithm. It shows the examiner you have a structured, logical thought process. And for trauma, a simple line drawing of manual inline stabilization is very effective. A good picture is worth 100 words.
And litter the text with the right keywords.
Oh yes. Gold standard, primary plan, rescue strategy, shared airway, ATLS protocol, C-spine precautions. These are the terms the examiner is actively scanning your paper for.
This is fantastic. So to summarize the whole thing in 2 sentences, TMJ.
Is an anticipated difficult airway, managed with a planned awake fiberoptic intubation, usually via the nasal route, where the challenge is the fixed mechanics.
And trauma.
Is an unanticipated difficult airway, managed as a crash induction with RSI and Mills, usually via the oral route, where the challenge is blood, debris, and anatomical distortion.
Perfect. Do you have a final mic drop sentence for us to put at the end of our exam answer?
I do. In both of these challenging scenarios, the anesthesiologist's primary responsibility is to have a clearly defined and immediately available backup plan, Plan B, and Plan C, because in airway management, failure to ventilate is not an option.
Airway first. It always comes back to that.
Always.
Well, that brings us to the end of this very specialized deep dive. To all our listeners out there preparing for the Gujarat University exams, we sincerely wish you the best of luck. When you have the knowledge now, just be sure to structure it well.
Stay calm, trust your training, and secure that airway.
This has been educational content based on the work found in Miller, Morgan, and Puneet Khanna. Next time, we're going to be looking at another high-stakes topic, the cardiac patient for non-cardiac surgery. You won't want to miss it.
We'll see you then.
Bye for now.